am very grateful to be a part of the program and faculty for this year's 24th Santa Fe Bone Symposium, and thank Mike and the whole team who makes this program so successful and so easy for all of us. So, and I hope that all of you have enjoyed not only this year's meeting, but plan to come back for the big party that will happen next year at the 25th Bone Symposium. I'm anxious to see how big a party that turns out to be. I'm very happy to see so many of the fellows who were part of the fellows program that preceded the Bone Symposium still be here. That makes me feel good. And I'm sure that they have enjoyed and appreciated the presentations that have been a part of this symposium as well. Mike always gives me a topic that I've never talked about before and makes me spend hours and days figuring out what I'm supposed to say about what he asked me to say, and that this year is no exception. It sounds like a simple topic, osteoporosis, drugs, and cardiovascular disease, but it's not straightforward, as you'll see. Here are my disclosures that really have nothing to do with much about what I'm going to talk about. You're aware that I'm on the board of the International Osteoporosis Foundation and the newly made American Society for Osteoporosis Providers. So again, many thanks to Mike and his whole team for making this be the best clinical bone conference in the country and for allowing me and Mandy to be a part of the faculty this year. So osteoporosis and cardiovascular disease are both common problems whose prevalence increases with advancing age. Fractures are more common in people who have vascular disease, and cardiovascular events are more common in patients who have osteoporosis. Here are data looking at the relationship between fracture risk and abdominal aortic calcification. The survival curves are stratified by levels of abdominal aortic calcification. Patients who have high abdominal aortic calcification have a higher frequency of fracture. Those two disorders share many common risk factors, including aging, the lack of physical activity, menopausal status, smoking, excessive alcohol intake. And there's again, as we said, an inverse relationship between bone density and bone mass measured by DEXA or any other technique and aortic vascular calcification. The processes involved in bone remodeling and in vascular calcification actually are quite similar. The vascular calcification is associated with the transdifferentiation of vascular smooth muscle cells into cells with an osteoblast, osteocyte phenotype. And that happens at sites of inflammation in the vessel wall. And of course, it's at that site where ultimately lipid deposition happens and plaque formation happens. In these vessel walls, where the transdifferentiation into osteoblastic-like cells happens, there are osteoblast secretory products that are many of the bone regulators that we're familiar with, including OPG, sclerostin, cathepsin K, and others. So the environment in a vessel that is undergoing vascular calcification is very much like the environment in a bone remodeling site. It's not clear whether the association of osteoporosis and cardiovascular disease is simply a matter of shared risk factors or whether it's the result of this shared, perhaps common pathophysiology. But because of that relationship, it's at least brings to mind the question of whether drugs that modulate bone remodeling and or its regulators might have effects in the cardiovascular system. So the studies that have looked at the effects of osteoporosis drugs on fracture risk were not designed to look at cardiovascular outcomes. And so the data that we have about that is not as complete as it would have been had they been designed as cardiology endpoint studies. So I reviewed the relationship between these approaches to osteoporosis management and cardiovascular disease. The 8 or 9 different things listed here. I did not include drugs like strontium ranelate that are not available to those of us in the United States. And it's not possible to cover all of the information that I now know in the hour total that's given to me. So we're going to focus on the 3 that I think that are most interesting and most queried among people that I interact with: the relationship between calcium and vitamin D in heart disease, bisphosphonates in heart disease, and romosozumab and heart disease. Here are the summary of the others very briefly, and I have included the data to support what I'm about to say in a big section of extra slides that it will be in the downloaded thing. So we heard this morning from Dr. Snyder that the FDA mandated the TRAVERSE study to look at the effect of testosterone therapy in men on cardiovascular events. And in that 5-year study, there was no effect of testosterone on cardiovascular events or mortality. We heard from Mandy about the relationship of estrogen therapy and cardiovascular disease, that in women who began therapy within 10 years of menopause, that there appears to be no increased risk of cardiovascular effects and maybe even cardioprotection. The more details about that are in the extra slides. Raloxifene was known to have a beneficial effect on cardiovascular risk factors with improvement in lipid profiles, and there was great hope that it would actually reduce cardiovascular risk. In the MORE trial, overall, there was no effect on cardiovascular risk, but in the subgroup of women at high risk for cardiovascular disease, there appeared to be cardiovascular protection. That led to the development of the RUTH trial, where women with risk factors for cardiovascular disease were enrolled and randomly assigned to raloxifene or placebo, followed for a long time, and overall there was no effect on cardiovascular disease, a very disappointing outcome of that study. But in that study, although there was no increased risk of stroke, there was an increased risk of death related to stroke that led to the box warning for raloxifene that we know. For denosumab, over 10 years of therapy, there was no signal of cardiovascular effects. PTH receptor agonist, Dr. Marcus and I have known for decades that PTH is a vasodilator, particularly when it's given intravenously into animals or into people. And in the clinical trials with both teriparatide and abaloparatide, there were symptoms related to orthostatic hypotension, including dizziness and tachycardia, but no serious cardiac outcomes. So then let's talk about the 3 major things. We know that adequate intakes of calcium and vitamin D are important for optimal bone health, particularly in children and in elderly adults. Calcium, like other nutrients, appears to be a threshold nutrient. Too little is not good. More than enough is not better. So once one reaches an adequate level of calcium, there's no additional benefit from higher intakes. Low vitamin D levels have been associated with an increased overall mortality and cardiovascular mortality, perhaps reflecting an association between poor health and low vitamin D levels. Low vitamin D levels occur in everybody who's sick without any specificity. So it's no surprise that correlations can be demonstrated between low vitamin D levels and almost any illness you can think about. There is uncertainty about the cardiovascular safety of calcium supplements in adults. It was believed that calcium might be cardioprotective. There's evidence that calcium increases the HDL-LDL ratios and lowers blood pressure in some studies that would be beneficial. But there's also concern that at least high calcium intake might be related to and to contribute to vascular calcification. It's very difficult to separate the effects of calcium and vitamin D in clinical trials because of their interplay physiologically, and that in many of the studies, both calcium and vitamin D are studied together. The concern about calcium supplements came from a study from colleagues in New Zealand. This was a bone density fracture endpoint study in which they enrolled older postmenopausal women whose mean age was 74.2 years, who were randomly assigned to receive calcium supplements or placebo, followed for 5 years with the intent of looking at the effect on fracture rate. The cardiovascular outcomes were a secondary endpoint that was pre-specified. The individuals were given 1,000 milligrams of elemental calcium per day as calcium carbonate. Vitamin D supplements were not given in this study. At baseline, the average calcium intake was 860 milligrams a day. So these patients were almost calcium replete before beginning the study and being given extra supplements. The average GFR was 61 mils per minute, and at least 40% of the patients had a known cardiovascular risk factor. Perhaps important, about a third of the subjects dropped out of the study within the first year, which decreased the statistical power to look at some of the questions that they wanted to address. Overall, there was no significant effect of calcium on MACE, on stroke risk, or on overall mortality. But there was, as shown in the figure, a statistically significant increased risk of myocardial infarction in the group that received calcium supplements, with a relative risk of 2.24 that, as you can see with the confidence intervals, is statistically significant. And those two curves began to diverge at about 2.5 years into the study. That led to analyses of cardiovascular outcomes in a whole variety of other studies, some of which were pre-planned, others not, and more meta-analyses than you can count. Perhaps the most important of these studies was the WHI, where there was a specific aim of looking at cardiovascular endpoints in both the estrogen arms of the study and in the calcium vitamin D component of the WHI. As you're aware, many thousands of women were enrolled in the study with mean age 62 years, with no history of breast or colorectal cancer, and they were assigned to receive either placebo or 400 milligrams of elemental calcium, that is 1,000 milligrams of calcium carbonate once a day, along with 400 units of vitamin D. That was the calcium D subgroup of the big WHI. Personal supplements up to 1,000 milligrams a day were allowed, and intakes of vitamin D were also allowed. So it wasn't a very clean study. And half of the women in the calcium D subgroup were from the estrogen arm and were either taking estrogen or not. So it's not a very clean, direct analysis of the effect of calcium and vitamin D on outcomes. Cardiovascular disease was looked at again quite carefully and prospectively. And at the end of the study, with a mean interval of follow-up of 7 years, 76% of women were still taking the study medication, including their calcium supplements had they been assigned that. And about 60% were relatively compliant in that they were taking at least 80% of the dose. Overall, there was no difference in the incidence of cardiovascular disease outcomes between the calcium D and the placebo group, either in the entire group or in a subgroup of women, of Black women who were at higher cardiovascular risk. Then the group in New Zealand did a reanalysis of the individual patient data from WHI and demonstrated significantly increased risk of myocardial infarction and stroke as a combined outcome, and of myocardial infarction and revascularization procedures as a separate subset in the 46% of the women who were randomized to calcium and vitamin D who were not taking personal calcium supplements at randomization. And they estimated hazard ratios of their cardiovascular outcomes ranging between 1.13 and 1.12. In the most recent follow-up of the WHI, after a median interval of 22 years, more information is presented to confound and confuse the picture. Overall, there was no effect on total cardiovascular disease or on overall mortality. But there was a 6% increase in the risk of cardiovascular death in the group that had originally been in the calcium vitamin D arm. Remember, this is now after 22 years. The study lasted 7 years, so we're 15 years beyond the study. And there's no information about what happens to calcium and vitamin D intake in the 15-year interval between the end of the study and now this analysis. So I'm not sure what we're supposed to make of that. They make a statement that leads us to be concerned about the possible association of calcium supplements and cardiovascular outcomes. Many meta-analyses have been done. The meta-analyses by the group in New Zealand, not surprisingly, showed an increased association of supplements and cardiovascular disease, but other meta-analyses have not. And there have been editorials arguing for and against the different methodologies and which data and studies should be included in the methodology. This has made the careers of many epidemiologists and has padded the CVs at the expense of confusing we mere clinicians. The National National Osteoporosis Foundation, now the BHOF, and the American Society for Preventive Cardiology have taken steps to assuage our concern about that by providing these statements: that there's moderate quality evidence that calcium with or without vitamin D intake from food or supplements has no relationship, beneficial or harmful, to the risk of cardiovascular and cerebrovascular disease, mortality, or all-cause mortality in generally healthy adults, and the calcium intake from foods and supplements that does not exceed the tolerable upper limit defined as 2,000 to 2,500 milligrams of calcium a day should be considered safe from a cardiovascular standpoint. I don't know about your experience, but this has not quieted the concern among patients who come and say, I just read this new thing in People magazine that says that calcium supplements make people have strokes. Why are you suggesting I keep my calcium up? A number of other studies have had cardiovascular endpoints. The VITAS study in New Zealand looked at vitamin D. No effect was observed on the primary endpoint of cardiovascular disease or death. The VITAL study that you know about looked at cardiovascular disease and cancer as the primary endpoints. No effect, no adverse effect on cardiovascular events was observed. And the Do Health trial looked at, again, 2,000 units of vitamin D a day and did not find any alteration either in blood pressure or a relationship to MACE events. So to summarize this set of, in my mind, confusing data, the hypothesis that calcium and or vitamin D supplements in healthy adults reduces cardiovascular risk, I think, can be put to rest. We don't need to advocate the role of calcium for cardiovascular benefit. But no study has evaluated the effects of supplementation of calcium and vitamin D in calcium and vitamin D deficient people. So this doesn't mean that we shouldn't provide adequate intakes of calcium and vitamin D. It just means that if people have adequate intakes, giving them more is not going to be helpful. And I think that makes common sense. We may never know if calcium supplements given to raise daily calcium intake above the adequate level has an effect on coronary calcification or cardiovascular events, but I contend we shouldn't care. We shouldn't advocate the use of calcium intakes above a daily intake of perhaps 1,500 milligrams a day, total intake, including dietary intake. Total calcium intakes higher than the recommended values that should be avoided, since higher intakes don't provide any additional skeletal benefit, only cause increased GI complaints, and we don't then have to worry about cardiovascular outcomes. Bisphosphonates were first used by German chemists as chelating agents to keep the scale from developing in the pipes in industry plants in Europe in the late 19th century. Non-nitrogen bisphosphonates like etidronate, we know impair bone mineralization, impair the deposition of calcium and mineral into osteoid, and they can reduce soft tissue calcification, and in animals are shown to slow vascular plaque formation. Remember that etidronate's first indication in the United States was to reduce the incidence of heterotopic calcium deposition in patients after hip fracture or after hip surgery. So we know that bisphosphonates, which are congeners of pyrophosphate, which, as Dr. Collins told us yesterday, is a really important inhibitor of mineralization, could have an effect. Nitrogen-containing bisphosphonates like alendronate and zoledronate and the ones we use today do not have an impairment of mineralization, at least in the doses used in animals and in clinical studies. But no one has specifically asked the question of whether they have an effect, good or bad, on vascular calcification. None of the large bisphosphonate fracture endpoint trials that were conducted in the 1990s adequately evaluated cardiovascular outcomes, but none of them demonstrated any effects on coronary artery disease or stroke. So the questions that people have based on more recent evidence or data, for example, from the ARCH study that we'll talk about, are, do bisphosphonates cause atrial fibrillation, and are bisphosphonates cardioprotective? With regard to atrial fibrillation, the concern, of course, rose in the Horizon trial, where patients were randomly assigned to receive placebo or annual infusions of zoledronate. Overall, there was no effect on cardiovascular outcomes, no increased incidence of atrial fibrillation, but an increased frequency of serious adverse cardiac events related to atrial fibrillation. The FDA defines a serious adverse event as one that results in death, that makes sense, or is associated with hospitalization. It has nothing to do with the severity of whatever the problem is. But if a patient is hospitalized and has an adverse event in hospital, it is categorized as a serious adverse event. After that was seen, you're aware that there was a second large study with zoledronate, the post-hip fracture trial, in which men and women who had had a recent hip fracture were begun on zoledronate or placebo within 3 months of the hip fracture and were followed over time. And in that study, if anything, there was a reduced frequency of serious adverse events related to atrial fibrillation. That led to reviews of all of the alendronate and rezidronate clinical trials. There was a trend toward increased frequency of serious adverse events related to atrial fibrillation with alendronate, but not with rezidronate. Then a whole bunch of case-controlled studies have come out. In Seattle, there was a higher incidence of atrial fibrillation in ever users of bisphosphonates, but not in current users, compared to never users. So you can tell your patients, if they're on bisphosphonates, if they don't want to have atrial fibrillation, don't stop therapy, is the take-home message. I'm teasing, of course. In Taiwan, in patients with a history of heart disease, bisphosphonate use was associated with a higher incidence of hospitalization for atrial fibrillation that would have qualified as a serious adverse event. In one Danish study, patients who began bisphosphonate therapy had a higher incidence of atrial fibrillation compared to patients who had had fractures who were not given bisphosphonates. But in a different Danish cohort, bisphosphonate use was not associated with an increased rate of atrial fibrillation or flutter. So are bisphosphonates cardioprotective? Again, this comes up in the ARCH study that we'll talk about soon. There is the post-hip fracture zoledronate study that I'll come back to mention here. Not only in that study was there a reduction in the frequency of fractures in the zoledronate group, but there was a 28% reduction in overall mortality in the zoledronate group compared to placebo group, and the cumulative incidence plot is shown here with the curves diverging at 1.5 years or so. The majority of the mortality, of course, was related to cardiovascular mortality. So when that was looked at as a subset, the cardiovascular mortality was 1.7% in the placebo group, 1% with zoledronate. That was not statistically significant because of the relatively small numbers, of course, with a p-value of 10. But that certainly suggests that zoledronate had an effect, a possible effect on cardiovascular mortality. Meta-analyses of all of the bisphosphonate trials have not demonstrated a reduction in cardiovascular risk, but I will remind you that cardiovascular endpoints were not collected and analyzed very assiduously. This was all collected as just a general adverse event profile in the history when patients came back for their follow-up visits in the clinic. Dr. Reed and the group from New Zealand made news again about cardiovascular outcomes in a study published in the New England Journal now 4 years ago. This is called the osteopenia study, although most of the women actually didn't have osteopenia because they could have had bone density measurements consistent with osteoporosis at one or more skeletal sites, and some of the women had previous vertebral fracture. But in that study, where they administered zoledronate once every 18 months, he wasn't brave enough to give it every other year, which is what he should have done, but he administered every 18 months or placebo and followed the women for a total of 8 years. And in that study, in women with a mean age of 71 years, 13% of whom had a history of heart disease, there was a reduction in myocardial infarction, a 40% reduction over the course of the study. So that, again, is a very interesting outcome with the use of zoledronate. A number of observational studies have suggested that bisphosphonate therapy is associated with decreased mortality or decreased cardiovascular outcomes. I've listed a number of those studies there for your perusal. So to summarize about bisphosphonates in cardiovascular disease, atrial fibrillation is not likely to be a problem. With oral bisphosphonates, there's still some uncertainty, I think, about whether zoledronate therapy is associated with atrial fibrillation, and we may never know. It's my personal belief that bisphosphonates probably are cardioprotective, but it would require a study with specifically looking for that outcome to convince all of us that that's true. And then lastly, let me turn to Romosozumab. When the phase 3 trials with Romosozumab were begun, we all knew that sclerostin was expressed in small amounts in vascular smooth muscle, given what I told you at the very beginning. And there are data demonstrating that sclerostin is expressed and present in the sites of aortic and vascular calcification and plaque. And so sclerostin expression is upregulated in those areas where vascular calcification is occurring. What we don't know is whether sclerostin is driving and promoting that calcification or whether it's a secondary consequence of the calcification pathophysiology. Remember, the phase 3 study with Romosozumab had 3 trials. The FRAME study, in which women received Romosozumab versus placebo for the first year, followed by denosumab, in which more than 7,100 women were enrolled in the study and followed ultimately for 3 years. The ARCH study is the study in which the cardiovascular concern arose. That was a study of more than 4,000 women at higher risk for fracture who were randomly assigned to receive either alendronate or Romosozumab for 12 months, followed by alendronate for an average of 33 months. And then the small men's bridging study in which men with osteoporosis received either placebo or Romosozumab for a year, where twice as many men were randomized to Romosozumab than to placebo, was the third study, a study that was written by and published by our host, Dr. Lewicki. So prior to the cardiovascular events being analyzed in the phase 3 studies, There had been a look at the phase 1 and phase 2 studies, and in those studies, there was no alteration in cardiovascular risk factors such as blood pressure, lipids, glucose metabolism. And then, as the phase 3 studies began, there was a prospective plan to have an independent set of cardiovascular experts review and adjudicate, is the verb, all of the serious cardiovascular adverse events in the phase 3 studies. These investigators were at the Duke Cardiac Research Institute, well-known group to monitor and oversee large cardiovascular outcome trials. They, of course, were blinded to not only treatment allocation, but to the study that the patient was in. They had pre-specified criteria by which they were to assess and review all of the serious cardiovascular adverse events. Overall, in the ARCH trial, there were a total of 1,703 serious adverse events and deaths, of which 346 were serious cardiovascular adverse events or deaths. And then after their review and adjudication, they wound up with 199 events that occurred during the first 12 months of the study. This was when alendronate was compared to romosozumab. Over the entirety of the study, a total of 686 adjudicated serious cardiac adverse events were identified. After the results of that adjudication demonstrated a significant difference in the frequency of MACE, major adverse cardiac events, a second independent adjudication of all cardiovascular events in the FRAME and ARCH trials was performed by the TIMI group in Boston, another prestigious cardiology group that's well known for producing studies with cardiovascular endpoints. The difference in the analysis was that the TIMI group had access to all adverse events, not just those categorized as being serious, and they then reviewed all of the adverse events and adjudicated whether the patient did or did not have a cardiac outcome. The TIMI group was blinded not only to the usual things, but also blinded to the results of the Duke adjudication process. Because the TIMI group's analysis and results were qualitatively the same as was seen in the DCRI, nobody knows the results of that, and we'll focus on the DCRI adverse events. So here are the results from the two large studies. In FRAME, again, more than 7,100 women. In ARCH, more than 4,000 women. In ARCH, there was a numeric imbalance in the number of serious cardiovascular adverse events, 2.5%. In the romosozumab arm, 1.9% in the alendronate arm. That was not statistically significant. After that was seen, the group at Duke performed an unplanned or a post hoc analysis confining the answer or confining the analysis to just patients with their favorite endpoint MACE. That's a common endpoint in cardiovascular studies. And when that was done, there was now a statistically significant difference in the event rate of MACE, 2% in the romosozumab arm, 1.1% in the alendronate arm, with a hazard ratio of 1.87. Note that in the FRAME study, a much larger study in which romosozumab was compared to placebo, and I will remind you that the gold standard for evaluating safety is a placebo-controlled trial. In that study, there was no cardiovascular signal, no imbalance in the rate of serious cardiovascular adverse events, and no difference in the rate of MACE events between the romosozumab group or the placebo group. I've taken the liberty of making a risk-benefit plot from the ARCH study, looking at the absolute numbers of patients who had cardiovascular serious adverse event or a MACE event. And then the gray bar, the third one in each group, is the difference between the two And if the bar extends below the line, that means there's more events in the Romosozumab group than in the control group. And then on the right part of the slide, the clinical fracture and major osteoporotic fracture rates, just to give you a sense of the relative frequency of cardiovascular events compared to the number of fractures prevented compared to alendronate in the first year of the study. If one looks at overall at the end of the study, where patients received a year of romosozumab or alendronate, followed then by alendronate for all of the patients, then the difference in terms of the number of adverse events and the number of good events is even more in favor of benefit. The question then came, why is there a difference in the outcomes of these two studies? Maybe we knew that women in the ARCH study were older by about 3 years. They had more severe osteoporosis, and maybe in older, sicker, less healthy people, romosozumab was harmful. So we had the chance to look at the frequency of cardiovascular risk factors in the two studies. And cardiovascular risk factors were common in both trials, slightly more common in the older women in the ARCH trial, but more than 60% of women in the FRAME study had cardiac risk factors, including about 5% of women who had had a heart attack or stroke before they entered into the study. And yet, despite the frequency of cardiac risk factors in the FRAME study, no cardiovascular signal was noted comparing romosozumab to placebo. We also took the opportunity to look at subgroup analyses of the ARCH study based upon a whole variety of cardiac risk factors. In most studies in which a drug or a disease has an adverse cardiac event, that is more evident in patients at risk for that particular problem. And in this analysis, there was no difference in the relative risk of MACE events across the spectrum of risk. So whether people were older or younger, whether they had a heart attack previously or not, whether they had hypertension or not, didn't matter. So this is not the typical pattern that we see when drugs are associated with an increased risk of fracture. At the FDA Advisory Committee hearing that I was fortunate to attend, we spent almost the entire day talking about the cardiovascular risk. Everybody agreed within the first 15 minutes that we didn't have to discuss the efficacy of romosozumab, and we spent the entire day working on this. And I think the most important data that I came away from was this graph, looking at the cumulative incidence of MACE in the romosozumab group shown in gold and the alendronate group shown in the lower thing. And you can see that the curves diverge early and stay diverged over the entire study period. There were two important features of this. The ratio of events between the two groups was the same at 3 months, 6 months, 3 months, 12 months, and at 24 months. That was an interesting finding. During the first 3 months of the study, there were no MACE events in the alendronate arm. This was really unusual. In the placebo arm of the FRAME study, MACE events began happening as soon as the study began and continued linearly over the entire study. So this unexplained absence of MACE events in the first 3 months of the study is unexplained. However, that absence of events during the first 3 months essentially sets the difference between the two treatment groups, because there's no worsening of the ratio of events with longer term therapy. And the second component of the graph that I thought was interesting is this. If romosozumab were harmful, or if alendronate was protective from cardiac events, one would have expected a downward inflection in the slope of events as patients were transitioned from romosozumab to alendronate. And we don't see that. The curve is linear throughout the entirety of the study as patients transition from romosozumab to alendronate. And FDA network meta-analysis compared the hazard of MACE in the alendronate arm of the ARCH trial to the placebo arm of the FRAME study, and suggested that with that comparison, there was a 45% risk reduction with alendronate compared to placebo. So that wasn't a formal study, of course, and you can quibble about the methodology, but that's an interesting observation. The MIN study was much smaller and compared Romosozumab to placebo, and you see that there was a numeric imbalance in the frequency of serious cardiac adverse events, no difference in the incidence of death, but this difference, although not statistically significant and comprising a very small number of individual people, led to concern at the FDA and was likely the reason that they did not approve Romosozumab for the treatment of men with osteoporosis. Other studies have also looked at the frequency of MACE events compared to controls. In the structure study, the Japanese phase 3 study, which was different from the FRAME study, and in the phase 2 studies, very small number of MACE events were seen, and these small studies, I think, don't contribute very much. The FDA and Amgen both perform meta-analyses of these studies. Not surprisingly, FRAME and ARCH dominate the meta-analyses because that's where all the patients and events were. And also not surprising, if you average the event rate in the FRAME study and the ARCH study, you'll get a number that's intermediate between the two answers. So not surprisingly, the hazard ratio, if you combine FRAME and ARCH, is 1.38. That is not quite statistically significant. If you add the very small bridge study, it doesn't change the outcome. If you add other small studies, it doesn't change the overall outcome, with a hazard ratio of roughly 1.4, but totally driven by the difference in the ARCH study. A very recently published study that you heard about yesterday from Dr. Belazikian took a real-world sample of patients in a global federated health research network who began therapy with either Romosozumab or teriparatide after propensity score matching. Cohorts of 5,610 patients in each group remained, and the major outcome was the 3-point MACE, which was statistically lower in the women who received Romosozumab than teriparatide. Does this mean that Romosozumab is better than teriparatide in terms of cardiovascular risk? The answer is obviously no. It's not a randomized trial. And if a patient has a history of cardiovascular disease, they're less likely to be given a drug that has a box warning for cardiovascular disease than is a drug like teriparatide, where that box warning doesn't exist. So my takeaway from this study is that we did not observe a clear increase in the risk of cardiovascular disease in the group receiving Romosozumab compared to those who received teriparatide. So the disparity between the incidence of MACE events in the ARCH and FRAME study remains unexplained. The timing of the difference that occurred early without progression with longer-term exposure is not consistent with most drug-induced cardiovascular harm studies. There was no difference in the relative risk between patients at low and high cardiovascular risk. Patients with lifelong sclerostin deficiency with the disorder of sclerosiosis do not have premature cardiovascular disease. A number of animal studies have been done since the clinical results were seen looking for a cardiovascular phenotype in animals who were either sclerostin deficient for their lifetime or who were treated with anti-sclerostin therapy mimicking Romosozumab therapy, and no evidence was seen. Human genetic studies have attempted to associate SOST gene variants that predict fracture risk and cardiovascular outcomes, and those studies have provided conflicting results. I've highlighted a meta-analysis of those 3 large studies just to highlight that the answers from the studies are different and conflicting, and in my mind, don't help me be smarter about whether to be concerned about this or not. If the associations that were shown are true, and for patients who are at risk for osteoporosis, would lowering sclerostin make them have more heart disease? If that were true, why didn't we see that in the FRAME study where we compared Romosozumab to placebo? I don't know how that could be explained. So some experts have weighed in on this. Dr. Cummings, who many of you know, say that together the data seen in the ARCH study indicate that the difference in rates of cardiovascular disease between alendronate and romosozumab is probably due to chance. Dr. Reed, whom I referred to, says that on balance, I believe it's unlikely that romosozumab does have detrimental effects on cardiovascular risk, but this remains an area that will require ongoing scrutiny and review. There are large surveillance studies being undertaken in Japan and the United States, so we are monitoring things with scrutiny. So in general, about romosozumab, the general safety profile is excellent. Whether romosozumab is associated with an increased risk of cardiovascular events remains uncertain, and we may never know the answer. Even the FDA acknowledges the uncertainty about the relationship between romosozumab and cardiovascular events. The FDA is usually very conservative in how they put together their boxed warning. But in this example, they say that Evenity may increase the risk of heart disease. If something may do something, it also might not. And the uncertainty is reflected in the language. The post-marketing surveillance studies I've mentioned, and until more information becomes available, the benefit risk of romosozumab should be considered in all patients, and it's prudent to use Evenity in patients who are at very high risk of fracture, to avoid its use in patients who are at very high risk for cardiovascular events. So to summarize, cardiovascular events and risk factors are common in our patients with osteoporosis. For people beginning osteoporosis therapy, identifying and controlling the cardiovascular risk factors should be a part of patient management, not just to ask which drug we should use. And for patients who are at very high cardiovascular risk or with recent cardiac events, perhaps we should use zoledronate and romosozumab with caution. With that, I'll conclude, and thank you very much for your attention.
Wow, thanks, Dr. McClung. That's amazing information. So there's a question on the chat line while people formulate their questions here. So this is sort of a clinical situation. A patient that previously took zoledronic acid for 2 years, then was switched to teriparatide, and then developed an AFib about a month following the initiation of the teriparatide. She did it for 17 months, but she wasn't able to continue due to insurance coverage. Shocking. Patient was then given options of switching to zoledronic acid versus Prolia, and the patient wanted to go back on zoledronic acid due to the fact that she tolerated it well and had some improvement in her bone density. So is it wrong to restart her on that with previous AFib?
No.
Next.
Does she still have AFib?
Apparently.
Well, if she already has AFib, another course of zoledronate is not going to induce it. So I'm not worried about that.
Good. And
Next.
Lynn, did you want to ask?
Mike told me to make short answers, so
Yeah.
I'm trying to comply.
Yeah. Lynn, do you want to ask your question? Lynn Kohlmeyer.
Lynn Kohlmeyer, yeah, I put it in the chat too, so
Yeah.
getting it in this time. So I think you answered it, but with all of the articles later, decades later from the WHI, why didn't they do just what you implied, separate out the women on estrogen and with or without progesterone, whether they had calcium or not? I didn't see that. You just said that 54% may.
No. I was not a part of the WHI, and had I been in charge of the world, I might have recommended that we do that, but I didn't have that opportunity. They can certainly go back and do that retrospectively, I'm sure.
So fantastic talk. We often see hip fracture patients or other geriatric fracture patients we operate on. They have to get a cardiac risk profile before we take them. They make it through the surgery. And then we have primary care
Right.
docs who are afraid to put people on romosozumab because they're worried about a cardiac risk. Like how do you explain that?
Right. So personally, we all know that as we get older, cardiac risk goes up. I discount that. Uh, uh, I think the cardiac risk that's important are patients who have uncontrolled risk factors, poorly controlled hypertension, poorly controlled diabetes, patients with recent cardiovascular or cerebrovascular events, unstable angina. If patients have had a stroke and a heart attack in the remote past, I don't worry much about that. So uh, I look at those additional risk factors on top of the inherent risk that accompanies aging. I think that, of course, if you do a Framingham risk score, whatever risk score you want to use, if for people my age, we're all at high risk, even though I'm standing here in front of you. And so I discount that part of risk. And again, would be reluctant until we have more information to begin therapy in patients who have unstable cardiac or cerebrovascular situations. So I don't ask cardiologists to see patients before I consider putting them on Romosozumab. Endocrinologists obviously are used to dealing with patients with diabetes in preparation for surgery or any other thing. So in taking a history and evaluating their blood pressure, evaluating their other metabolic issues, internists are comfortable or used to making those sorts of decisions.
Thank you.